What I'd like to do today is just give you a general sense of the university's vision, where we're trying to take things. Obviously, BRISSKit is a major part of that, and I hope it will be clear how that fits in. And I think my talk now sits very nicely between the demo we had, kind of, the very technical, on-the-ground work that's being done, and then the bigger strategic picture that's just been presented. So I hope I can come in somewhere between the two. What I'm not going to do is give any real technical detail on any points. I'm trying to just picture vision. That's not just my vision, it's very much the University of Leicester Leicester vision that's been developed with many colleagues here. And for those of you that don't know, we're soon to move in, many of us are soon to move into a new building, purpose-built building, called the CRC, the Cardiovascular Research Centre, where 2 floors will be on informatics. And those 2 floors we're calling the DKP, the Data to Knowledge for Practice facility. I'll be the inaugural director of that, but we'll share that directorship around. Many of us will move in there and work as a team to try to pull this vision together. So, with that all said, I'll try to show you the vision. Do I move with, is it the keyboard I use for this? Okay, so let's have a look at what we have in Leicester. I've listed at the top there on the first line a number of major EU projects that I'm involved in, and I'm sure there are many more that others from Leicester can list here as well. But just to give you a sense, this Gen2Fen project, a €12 million project connecting genotype to phenotype data, all the technologies around that that allow us to bring those kind of resources together to use them holistically for research and healthcare. BioShare, similar approach, a project now running, another 12 million EU project for biobanking data, how we manage and use that, and biobanking science as well. ITFOM, it's meant to be a European flagship project, up to €1 billion. It's now down to the last 6 in the competition. We've had 1 year to put the plan together. We were selected from 26 to be one of these top 6 that were funded to make a plan. That's now been submitted as our final proposal, and they will fund 2 of those projects, 2 flagship projects in Europe. So we have a 1 in 3 chance of being major partners in this €1 billion program. EMIF, European Medical Informatics Framework. This is how we tap into health data, not just hospital data, but all sorts of health data, and how we connect that into research. It's a sister project, it's a €50 million project, sister project of one called eTrix, doing the same for research data. And so there's obviously a lot of interactions between those 2 programs. And many other collaborations that I just can't list on one slide. And I wouldn't be surprised if all the other people involved in this new DKP facility are going to have a similar list of activities. Partnerships with DMUDB. This is at the moment the UK diagnostic database, but it's now reaching out to become an international diagnostic database run from Manchester. We have a partnership with them, and we've just submitted a joint application to extend that work. Obviously, various platforms in Leicester. You've heard about BRISSKit here. It's a major thing, not just now for Leicester, but for the UK and possibly beyond. BBASH services. This is an informatics services system we have in Leicester. And so on. Excellent biostatistics, social sciences, maths, physics. We have these 3 BRUs that you'll hear about today. And out of these kind of activities, there's many, many products, tools, systems, solutions that are now up and running and used widely internationally. So I think we're very strong in Leicester. The trick is that we're just going to keep doing this as separate projects, or can we bring all of this together in one system, one integrated program, essentially? And as inaugural director of this DKP, that's going to be my mission, to try to get everyone working synergistically. So, where are we with, not just we, but internationally, with research databasing? Essentially, a lot's been done in the last few years. All different types of databases are going from disconnected, differently designed systems to much more standardized, interoperable system, very much connecting through a pyramidal type structures from local databases where lots of detail and controlled access apply, up through to the top major genome browsers and holistic search systems. That's all coming together wonderfully. I hope Gen2Fen has contributed to that, but many other programs are building that kind of global infrastructure. And it's intended to be serving research and healthcare. The problem, it does not. It serves research very well, but it does not really do much good for healthcare. And we started realizing this very early on in the Gen2Fen program, that something's not working. You can build this wonderful infrastructure, but why doesn't it really help the doctor and the patient? And it certainly doesn't do what we need it to do, which is to process the data in a way that make them optimally useful for the clinical encounter, clinical diagnostics. So we've put a lot of work in Gentofen in trying to work out why this is, and we've been sharing those ideas with people in Leicester, and really this is now the problem slide. After this I'll move on to the solution slides. But the problem we've realized is that research and healthcare are a long way apart on an axis. They're not a continuum, they're separate worlds, separate universes. We cannot simply reconcile them, bring them together, no matter how hard we try. We have to understand the differences in them and create bridges that close the gap between them. So we need data to flow around from one to the other and back again to create virtuous circles. Obviously biobanks and registries are part of that. And we have to deal with different communities, the bioinformaticians and the academics on one side, and the medical informatics and the companies that serve the health sector on the other side. So the core point is there is a gap between these two worlds. How do we bridge that gap? Well, we don't reconcile them, as I said. We need to create the bridge, and we see that bridge as being about knowledge engineering. The key word here being engineering. It's not research, it's not healthcare provision, it's not medical practice. It's engineering, IT engineering. And this slide just kind of tries to represent that as a link in a chain between these research and healthcare domains, and then points out all the opportunities and the challenges and the questions that come out of that. So one thing that we've put together is this idea of if it's a bridge, a gap, and you need to build a bridge, we have created a community of over 200 institutions, organizations, key labs that see the world the same way. We've had many workshops with these over the last few years to work out what is needed to bridge this gap. That community has become called I4Health, standing for Integration and Interpretation of Information for Individualized Healthcare. There's a website there, and you can go and look up the participants in that network and the ideas we have. So coming back to this, I hope I've shown you or given you a sense that this infrastructure, this architecture that's out there for research data management is not serving healthcare, and instead we need something more like this. It's a little bit of a complicated slide, but very briefly, on the left here we have the research world, and that infrastructure that I've just shown would fit over here. On the right-hand side, we have the healthcare world, where you've got all the different modalities of data generation, EHRs of one flavor or another, BRISSKit being a form of EHR, I would argue, and all the clinical decision support and diagnostics you need that will come out of that. And in fact, the strange thing is the public think this is how this works already, but it clearly does not. What we need is for those research data to be processed to identify the useful knowledge in the data. That knowledge can then be used to guide the biomarker and the clinically useful activities that come out of that knowledge. They would then feed in with the patient-specific information to the clinical diagnostics. Equally, there will be a flow back up there from the health data back into the research world, very much in line with the talk you've just heard. So how do we create this kind of fully functional system? Well, what I would argue is that the key here is the engineering component, and we're calling that knowledge engineering, but we're not going to claim we've invented this concept. This term, knowledge engineering, first came up in 1983, where people in other domains realized that you need to put data together in very clever ways to make it useful, to convert it into knowledge. And there's a definition they came up this group back in 1983. But talking to people from those teams, actually, they've lost interest in that approach. And I think we need to think a bit more deeply. So in a couple of slides, I'm going to try to give you a bit more of an insight into what knowledge engineering is and is not. So I'm now calling this knowledge engineering version 1.0. This is what was really the concept from the 1983 and onwards, and it's really suitable for research activities around knowledge engineering. We start with a human, and there's lots of bits of information you can generate, lots of bits of data you can generate. Of course, in this graphic, these data are Lego bricks. Now, if I have all of this information, all of these Lego bricks coming out of a person from lots of research activities, what can I make out of Lego bricks? I'm sure you've done it yourself and your children are doing it all the time. You can make many different things, depending on what mood you're in, all with the same bits of information. And that's why some knowledge engineers have lost interest in the concept, because they say, well, you know, if you start with certain assumptions or certain biases, you can come up with different bits of knowledge from the same data. What is truth? Which bits are reliable? Which bits can be used? Well, I would argue that's the strength of knowledge engineering for research. The point about research data and research knowledge management or data management is that you should be able to play with data in all sorts of ways to come up with new hypotheses, to create new ideas, to explore. That's why the data have to be arranged in the ways they are being arranged for research purposes, where you can get to everything and you can play with the data. But that's knowledge management version 1.0. What about what we need for healthcare? It's a different form of knowledge management. So we're calling this version 2.0. And I'll just recap quickly what I've said. What we've been doing in the past is trying to move data all into one place from the clinical world into one big box or one big infrastructure, and then make sense of it. That's the knowledge engineering 1.0 for research purposes. Knowledge engineering 2.0 is instead looking at those data and not trying to understand everything, not trying to come up with absolute, complete knowledge, but just identifying the bits that we can see will be useful. Distilling out the useful bits of information and then making use of them. For example, a rectangle, very simple shape, we know how to use it. A circle, simple shape, we can work out how to use it. Let's leave all those other complicated shapes, those other possible interpretations of the data for another day, or just let the researchers play with that. So for healthcare, we need a different approach to the information. In summary, we need to distill out the useful parts and hand them over to healthcare professionals in a way and a format they can use them most efficiently. So that's the general concept. It's about knowledge engineering. It's about connecting research and healthcare informatics systems, bridging this gap in a way that both parties get out of it what they need. They don't need the same thing. They don't need the same analytical approaches. They don't need the information provided in the same kind of formats or ways. To do that, we need to concentrate on, not just Leicester, the world needs to concentrate on many different things. All the standards, a whole series of standardization needs to occur. Computer modeling, both for personalized medicine and for stratified medicine. There are different approaches to modeling you need to consider there. Electronic healthcare records. It would be wonderful if we did have one after the IT Connecting for Health program, but we don't quite yet have that, as you all know. So yes, the first step is to build things like BRISSKit, where it gives the same functionality as a global EHR would. And then we need to think about data sharing. And here I would suggest that we can actually think of the universe of relevant data in three categories. There's the safe stuff that you can share openly. Let's share it openly. But the vast majority of it is going to be mildly risky, mildly sensitive data, and arguably we can best handle that by putting it on a cloud, by setting up fully automated access systems, which we would call speed pass, based on universal identifiers for researchers and participants in this space, and the ORCID system is now being launched in the next month or so to enable that. And only a small fraction of the data need to be completely, tightly controlled, and there are systems for doing that as well. So it's a three-level perspective on data sharing, and then lots of tooling and strategies amongst those three levels for how we could actually do that data sharing. Ultimately, though, it still comes back to this challenge of identifying the useful bits and then handing them on to make them useful to the people that need them. And so at the heart of that objective, we have this concept called a knowledge portal. This is where that distillation process takes place. What do I mean by knowledge portal? Well, here's an example of one that we have designed and are trying to get funding for around rare disease informatics, rare disease diagnostics. A whole bunch of tooling, it's all available out there. All we need to do is bring it under one roof and integrate it all. So this isn't rocket science. This can be done and provide a perfect knowledge portal for specific subdomains of rare disease and diagnostics. And you can then very quickly imagine lots of those knowledge portals for different domains all coming together and outputs of those being integrated in various ways to create the fully functional system that goes beyond one disease or one disease category or one domain. And the power of this system would be that it would be self-optimizing. The outputs from any level, if they weren't working quite well for the end user, that the way they didn't work or the way they need to be improved could be fed back into the system. So it would become, both in automatic and manually organized ways, self-optimizing. So those are the ideas that have come out, not just from us, as I say, from lots of people working around Europe, but in Leicester we've worked out a strategy for trying to put all of those bits together and pilot these kind of concepts. That environment will be this cardiovascular research centre. It's illustrated here, the building is finished, we'll be moving in next month, and the top 2 floors will be the informatics aspects, trying to do this knowledge engineering to bridge the gap between research and healthcare informatics. And I think I had one more slide. No, that was it. Thank you very much.